Hello, everyone. It is now noon, which means we are going to get started. Welcome, everyone, to today's exciting webinar entitled An Introduction to Working with People with Intellectual and/or Developmental Disabilities Across Healthcare Settings. Today's MC is going to be New York State's very own Dr. James V. McDonald, the Commissioner of the New York State Department of Health. Well, I'm the producer today. My name is Christian Harris-Simchuk. I work with the Center for Public Health Continuing Education at the University at Albany School of Public Health. And no, the last name will not be part of any kind of evaluation or post-test. It's too long. We have some disclosures today. The planners, moderator, and presenters do not have any financial arrangements or affiliations with any ineligible companies whose products, research, or services may be discussed in this activity. In addition, no commercial funding has been accepted for this activity. Regarding evaluation and continuing education credits, we are offering 4 types of credits for this offering. They are continuing medical education credits, continuing nurse education contact hours, certified health education specialist contact hours, and certified in public health renewal credits. To receive continuing education credits, please fill out the evaluation and post-test. And on that note, those links will be provided toward the end of this webinar. We also have some objectives and a learning outcome today. By the end of the webcast, viewers will be able to recognize disparities in healthcare outcomes for people with developmental disabilities, identify barriers to care for people with developmental disabilities, and describe strategies for appropriately working with people with developmental disabilities. Today's learning outcome is as follows. As a result of participation in this activity, the learners will increase and enhance knowledge and competence on culturally competent strategies for addressing disparate healthcare outcomes for persons with intellectual and/or developmental disabilities. For those of us who may be new to Zoom, there probably aren't too many of us, but regardless, please use the chat box today for pretty much anything that's going to be technical issues, as well as questions for the speakers, which will be addressed toward the end of the webinar. We do have live transcription enabled. To turn that on or off, please use the option on your bottom bar. And lastly, this webinar is being recorded. I now have the pleasure of introducing Dr. Erin Bell, who I will spotlight for everyone right now. Okay, Dr. Erin Bell is the interim dean of the University at Albany School of Public Health. She has partnered with researchers at New York State Department of Health for over 20 years on studies related to health and development of infants and children, and most recently assessed the health effects for communities living with drinking water contaminated with PFAS. So, Dr. Bell, without further ado, I will turn it over to you.
Thank you very much, Chris. It's a pleasure to join all of you today, especially on such an important topic, something near and dear to my heart, given my own research background, and it ties in so nicely with so many of our goals here at the School of Public Health. As many of you know, we have a long-standing partnership with the New York State Department of Health. This is a unique partnership and so important to the continued professional development and growth of our public health workforce. I'm particularly excited to highlight the critical work of our host today, the Center for Public Health Continuing Education. The center was established to provide education and training for the public health and healthcare workforce and is recognized nationally for their public health live programming. And given their ability to provide a number of continuing education credits, as you just saw, across multiple fields within public health and healthcare, including the grand rounds today, they are a cornerstone and a point of great pride for our school. I'm pleased to introduce you today to Dr. James McDonald, our Commissioner of Health here in New York State at the Department of Health. Prior to joining us in New York, Dr. McDonald served in multiple senior roles at the Rhode Island Department of Health, including his service as the Interim Director of Health and the Chief Administrative Officer of the Board of Medical Licensure and Discipline, and Medical Director of the COVID Unit and the Drug Overdose Prevention Programs. He earned his MD from Loyola Stritch School of Medicine, completed his pediatric residency in the U.S. Navy before completing his preventive medicine residency with our own School of Public Health, and earned an MPH from the University of North Carolina at Chapel Hill. As noted, he has previously served in the U.S. Navy and as medical director of the outpatient medicine clinic in Chinle, Arizona, while serving in the Indian Health Service in the Navajo Nation. We are fortunate to work and partner with Dr. McDonald, and it is my pleasure to hand it off to him. Thank you.
Yeah, thank you, Dr. Bell. It's great to be with everybody today, and really glad to have this topic we're discussing today. Welcome to our third Commissioner's Grand Rounds for 2023. I hope this topic is near and dear to you. I want to just ask Sarah Snyder, who's with me right now, if she would put the link into our previous Commissioner's Grand Rounds. I think you'll find that helpful if you'd like to see some of our other topics. So our last one covered how hospitals can prevent gun violence, which was really great. And we also talked about how climate change has been an issue in health. And when I talk about climate change, talk about how the climate has changed, because it indeed has changed already. And as we dive into today's topic, I just want to, highlight a personal interest in this issue. I'm a dad of 3 children, very proud of all 3 of my children. How I have 2 kids who are adults with intellectual and developmental disabilities. And it's been just an education for me to watch them navigate life and learn how life has much to offer. And, one of the things I think about with my Noah in particular, who's got autism, and just how he's really just overcome challenges. My son's really become a very happy adult. He's working part-time and a very wise man in his own right, who I have learned a lot from. And my Christopher, I'm very proud of as well, who's, working his way at his own speed through college, which I think is really important as well. But just really one of the things I've seen is just the challenges that really children with intellectual and developmental disabilities face, and how they're not always easy to overcome, but sometimes they're quite possible too. I do want to thank the UAlbany staff who's helping us put this program on. I also want to thank Dr. Haley Gilmore, who's with me today, and Sarah Snyder for their help in putting our CME together, as well as the panel discussion. I think it's great. I want to set a little bit of context as we could. We're going to embark on a discussion that I think is just relevant and challenging. And, and I'm really thrilled to have Commissioner Neifeld with us today from the Office of People with Developmental Disabilities. And they serve about 130,000 folks with intellectual and developmental disabilities in New York. And, as I've said, these individuals often face difficulty in finding appropriately trained and willing healthcare providers. And, it's interesting. Over my career as a pediatrician, I've been a pediatrician 33 and a half years. And I don't know that I've had formal training in helping children and young adults with intellectual and developmental disabilities. I've just sort of acquired it as I've gone on. And I think this is important to have specific training. And, one of the things I worry about when I listen to patients with intellectual and developmental disabilities, so sometimes they don't always feel welcome in healthcare providers' office and don't always feel valued, don't always have access to the same care. And those, of course, lead to health disparities. One of the things I want to highlight as well, in the fall of 2022, the Department of Health and the Office of People with Developmental Disabilities initiated a collaboration to establish a cross-agency work group. Our agencies have worked well together in the past, but just nice to formalize that. And part of the collaboration, though, is really to address bias and discrimination and ultimately improve the healthcare outcomes and healthcare services across our state for people with intellectual and developmental disabilities. And this work really is broken down to 3 particular work streams: 1 focusing on education and training, 2 on reimbursement and other financial incentives, and 3 in enforcement. I want to just talk a little bit about our work to date on education and training. The Office of the Commissioner, with our Office of Health Equity and Human Rights and the Office for People with Developmental Disabilities, is tasked with identifying and developing educational training resources for providers and staff serving New Yorkers with intellectual and developmental disabilities. Health Department received a 5-year disability and health grant from our federal department, the U.S. Centers for Disease Control and Prevention, highlighting that training is a significant component of this grant. And New York is one of 10 states to receive this funding, which calls for all the grantee states to collaborate and offer 2 trainings from the University of New Hampshire. And I think maybe Sarah could put those links in the chat box right now in case you're looking for even more additional continuing medical education. The cross-agency collaboration between the Department of Health and the Office of People with Developmental Disabilities work group is informed by the Health Department's Disability and Health Program. Our Disability and Health Program plays a pivotal role in supporting the education training workstream. This program also aligns with the department's commitment to addressing healthcare needs and eliminating health disparities. This program of disability health spans multiple states and has become an integral part of our strategy to really work on improving folks' skills and knowledge and really providing optimal patient care. In essence, our collective efforts are aimed at dismantling these barriers to healthcare access for individuals with intellectual and developmental disabilities. I want to talk a little bit too briefly about federal and state initiatives. While our focus today is on New York, it's essential to acknowledge the broader context of federal initiatives addressing the healthcare needs of individuals with developmental disabilities. The Center for Disease Control and Prevention Disability and Health Grant, which New York does receive, exemplifies a national commitment to addressing health disparities among individuals with developmental disabilities. In addition, federal legislation, including the American with Disabilities Act, ensures individuals with disabilities, including those with intellectual and developmental disabilities, have equal access to healthcare services. These legislative frameworks set the stage for state-level collaboration and initiatives. In New York, the Department of Health and the Office of People with Developmental Disabilities work group is a testament to the state's commitment to addressing the unique challenges faced by individuals with intellectual disabilities. And this collaboration aligns with our federal goals of improving healthcare access, eliminating disparities, and making sure people feel welcome. It's called inclusivity. These work streams of cross-agency education, training, reimbursement, other financial incentives, and enforcement mirror the comprehensive approach needed to create lasting change. So in today's Grand Rounds, we're going to hear about the barriers to care people with developmental disabilities face and introduce providers to working with people with intellectual or developmental disabilities. Our focus today is not just on identifying these challenges, but providing valuable insights to healthcare providers for delivering culturally competent care to this diverse population. We have two experts who will share their experience working with individuals in this area, and they're going to shed light on what providers can do to provide culturally competent care. And following their presentation, I'm going to lead a series of questions to further explore their insights and experiences in working with individuals with intellectual and developmental disabilities. And I do encourage you to stay for the question and answer time. I think sometimes those customized question and answers can really provide a lot of insight. And as adult learners, I think we often learn from just hearing each other's questions and sharing insights like that. And then to enrich our understanding, the session is going to conclude with a presentation and conversations featuring a person with lived experience, offering a direct perspective on the needs of individuals with developmental disabilities when navigating the healthcare system. So let me just take a moment just to let you know who our speakers are going to be today. We have Dr. Vincent Siasoko, who's a board certified family physician specializing in intellectual and developmental disabilities. He's the assistant professor in the Department of Family and Social Medicine Pediatrics at the Albert Einstein College of Medicine. He's the director of primary care at the Rose F. Kennedy Children's Evaluation and Rehabilitation Center. He's actively involved in leadership roles, including serving on the board of directors of the American Academy of Developmental Medicine and Dentistry. We also have Dr. Stephen Selkos with us today, professor of developmental and behavioral pediatrics at the University of Rochester Medical Center. He's co-director of the Strong Center for Developmental Disabilities, a University Center of Excellence in the developmental disabilities. And he brings a lot of experience in developmental behavioral pediatrics with a focus on policy and practice. Actively involved in advancing research, education, and service through the Association of University Centers of Disabilities. Also happy today to have Isel Obermeyer with us. She's the Chief Clinical Officer at the Westchester Institute for Human Development. Her background as an occupational therapist with global experience in various countries, oversees adult health services, behavioral health programs, dental programs, and more at the Westchester Institute for Human Development. She's an active advocate for assistive technology inclusion in schools and a project leader for Multimedia Technology Center at the Westchester Institute for Human Development. And also, we're thrilled today to have Claire Pollan, a self-advocate and a person with lived experience, who's going to talk about, as an advocate and member of our Hear Our Voices organization, passionate about improving the quality of care for individuals with disabilities in medical settings and a certified sexual education teacher for people with disabilities, and serves as a mentor to high school students with disabilities. So there we go. All right, thank you so much. And I'd like now to just welcome Commissioner Carrie Neifeld. And Commissioner Neifeld, let me turn it over to you, who's our Commissioner of the Office of People with Developmental Disabilities. Commissioner Neifeld.
Good afternoon, everyone. Thank you so much for being here today. And thank you, Dr. McDonald, for inviting the Office for People with Developmental Disabilities to be part of today's medical grand round session. We are so grateful for our partnership with the Department of Health and Dr. McDonald, and for their commitment to improving access to quality healthcare for people with developmental disabilities. Today is an important opportunity to have a discussion about the barriers to healthcare faced by people with developmental disabilities, and to explore opportunities to break down those barriers. We know bringing awareness to the issue is an important step in reducing those barriers to medical care for people with developmental disabilities. We look forward to continuing to work with the Department of Health on other opportunities to increase health equity and access to care for people with developmental disabilities, as Dr. McDonald highlighted in his opening remarks. I also want to thank Dr. Erin Bell, the Interim Dean at SUNY Albany School of Public Health. Without the School of Public Health partnership, this project would not be possible. And finally, I want to thank the staff at DOH and OPWDD. Specifically within OPWDD, I want to thank Rachel Baker, Dr. Jill Pettinger, Jeannie Kavanaugh, and Diane Woodward for the months spent organizing and developing the content for today's event. We are thrilled to have the opportunity to join the Department of Health, the School of Public Health, and our guest speakers in creating the vision for this medical grand rounds. As Dr. McDonald mentioned, OPWDD provides services to approximately 130,000 New Yorkers, adults and children with intellectual and developmental disabilities, including cerebral palsy, Down syndrome, autism spectrum disorders, Prader-Willi syndrome, and other neurological impairments. We provide services directly as a state and through a network of approximately 500 not-for-profit agencies. OPWDD coordinates and provides supports and services that help people with intellectual and developmental disabilities live full and independent lives. Over the last several years, OPWDD has conducted extensive stakeholder engagement where we have heard increasing concerns from our community related to healthcare services. People from across the state are raising concerns about their access to healthcare and the quality of that care. We have heard from people with developmental disabilities and their families that there is a lack of providers trained to meet their needs. There's a lack of accessible offices and offices physically equipped to meet their needs. That people have to travel many hours to see trained providers, and that most trained providers have wait lists that can last from months up to multiple years. People have been denied hospital care due to their disability, and we have heard that there is a need for more doctors and therapists who are trained and have experience in working with people with developmental disabilities. While some of these concerns and issues, like difficulties finding providers and long wait times, are unfortunately universal, many of them are felt only or felt more acutely by people with developmental disabilities. And those are the issues that we know we can and must focus on improving. Unfortunately, New York is not unique. Nationally, people with disabilities of all types struggle to access medical care. According to the CDC, 1 in 4 adults with disabilities age 18 to 44 years do not have a consistent healthcare provider. 1 in 4 adults with disabilities in the same age group have an unmet healthcare need due to cost. 1 in 5 adults with disabilities age 45 to 64 did not have a routine checkup in the last year. And overall, people with disabilities were about twice as likely as those with no disability to skip or delay medical care. In September, the National Institutes of Health designated people with disabilities as a health disparities population, making new funding available for research on improving access and outcomes for people with disabilities. We look forward to seeing the new research being done as a result of this funding. In a study published in the fall of 2022, medical professionals self-identified numerous barriers to care, including physical barriers and accommodation, communication barriers, knowledge, experience, and skills barriers, structural barriers, and poor attitudes towards people with disabilities. Our speakers today will be going into further depth on the barriers people with intellectual and developmental disabilities face when accessing healthcare, but I want to speak in a little bit more detail on the areas that we at OPWDD hear about most frequently, those being physical barriers, barriers related to education, and attitudinal barriers. Physical barriers are something we hear about very often in the OPWDD communities, with doctors' offices being physically inaccessible or lacking accessible medical equipment needed to properly examine a person and/or to provide the medical care that they need. I want to share a short anecdote because I think it really speaks volumes about the challenges people with disabilities can face when attempting access to medical care. Recently, a woman who uses a wheelchair was referred to a local health clinic that primarily serves people with developmental disabilities, and she shared this story with her new provider. Her previous primary care provider did not have a wheelchair accessible scale in his office, and instead, he sent her to a bottling plant to be weighed prior to her routine appointments. So in order to have her weight checked, which was so important to monitoring her health, she would wheel herself into a bottling plant, past the lines of workers, and onto a scale that was meant to weigh boxes and pallets before they were shipped out. She was demoralized by this experience naturally, and this story just illustrates the type of dehumanizing and embarrassing experiences that people with disabilities face every day as they attempt to access competent medical care in a dignified way. As I said, this is just one example and one story, but I could share many more, as can the people who have these experiences in offices across the state every day. These experiences have the potential to make a person with a disability not want to return to a doctor's office to seek needed care, leading to poor health and quality of life outcomes. In terms of educational barriers, most medical professionals do not receive training specific to treating people with disabilities as part of the standard medical education, and many lack the sufficient knowledge, experience, and skills to care for people with disabilities. There are existing training programs specific to disabilities that do phenomenal work, but these programs are limited in scope and size, reaching very few medical professionals each year. Finally, we know that providers often have negative biases toward people with disabilities. These attitudes can lead medical professionals to deprioritize the needs of people with disabilities. It can lead them to assume that people with a disability cannot speak for themselves or comprehend what is going on, or deny care altogether because they are unsure how to provide it. These biases lead to poor experience of care for people with developmental disabilities. And as we all know, when we have a poor experience with the doctor, we are less inclined to go see that doctor or any other doctor again. The consequences of these barriers is that people with disabilities are more likely to report poor health outcomes and experience higher rates of chronic health conditions than people without disabilities. People with developmental disabilities experience lower rates of preventative screening, higher rates of obesity, diabetes, and cardiovascular disease. They have lower life expectancy and higher rates of pregnancy complication. Today, our invited speakers will be focusing on how we start to remove these barriers for people with developmental disabilities face, increase access to healthcare, and improve outcomes for people with developmental disabilities. We are extremely happy to have with us today the co-chairs of the OPWDD Medical Task Force, Dr. Selkis and Dr. Siasoko. The OPWDD Medical Task Force is comprised of physicians throughout the state with unique expertise in serving people with developmental disabilities who have come together to work on special projects to improve the quality of medical and healthcare for this population. Their goals also include decreasing risk for people with developmental disabilities and increasing education to the community and other healthcare providers. These physicians give freely of their time, and we are grateful for their service and their commitment to people with intellectual and developmental disabilities. Without further ado, it is my pleasure to introduce Dr. Selkis and Dr. Siasoko. Thank you.
Thank you, Commissioner Neifeld. So I'm Dr. Vincent Siasoko. I'm honored to be here. I'm a family physician based in the New York City, Long Island region. So today we're going to be talking about an introduction to working with people with intellectual and/or developmental disabilities across healthcare settings. So, I wanted to start off the session with a quote from a Dr. Rhoda Olkin. She's a distinguished professor of psychology with a disability herself. And she stated, "How people think about disability affects how they feel about disability." I think all of us have different thoughts and perspectives on disabilities. How do those with disabilities take care of themselves or have others care for them? How do we as healthcare providers or family members take care of those with disabilities? Disabilities can be looked at through different multiple lenses. And there exist three different thoughts, three different models of disability: the moral model, the medical model, and the social model. Now, the moral model states that disability is viewed as being caused by a person's or family's character, deeds, or thoughts. From this perspective, disability can be thought to carry stigma, shame, or blame, particularly if the disability is seen as a mark of wrongdoing, or it can be seen as a sign of honor, faith, and strength, and it can be seen as a positive light. The medical model is viewing disability as a medical problem or illness that needs to be solved or cured by professionals. There's a problem, there's an illness. As a physician, we've got to address the issue and only the issue. Whereas in the social model, disability is viewed from the perspective of having the disability as only one aspect of a person's identity, similar to race, ethnicity, and gender. The barriers are seen from a societal or environmental perspective. So looking at these different models, I thought it'd be best to understand, to give, for example, a patient scenario and see how the medical and the social model interact. So a scenario is as thus: a 20-year-old female with cerebral palsy, spastic quadriplegia, uses a wheelchair. Spastic quadriplegia meaning all four of her extremities, upper and lower extremities, are all spastic. She has mild intellectual disabilities. She's dysarthric, meaning she can't communicate well. The words aren't coming out clearly. She has complex medical needs. And this lady is now hospitalized for pneumonia. She's accompanied by her mother, who's been at her side during the entire admission. And unfortunately now, the patient's having problems with her breathing, and the physicians can't understand the communication of the patient or the mother. From the medical model perspective, in general, severe disability is assumed to represent a lower quality of life. This new illness, this pneumonia, is only increasing her suffering and adds to the heavy burden already placed on the mother and the caregivers. Since the physician isn't understanding the patient's wishes or understanding what the mom's trying to convey on her behalf, the hospital staff is having issues with communication as well. They encourage the mother to let nature take its course. Unfortunately, the hospitalization becomes prolonged. The relationship between the patient, the family members, the caregivers, and the hospital staff break down, and unfortunately can lead to complications. It's more the medical model, but when we think of the medical model, it's different than the social model. So when you look at the lens through the social model, we're looking at this patient as an individual. Her life is valuable. It's meaningful, regardless of her disability. The woman has chosen her mom to help make and communicate her medical decisions. Those decisions should be respected. So in a social model, if we're looking at it a different way, addressing the environment, what we want to do is make sure the patient is treated well and that there's a speedy and safe discharge. So they'll maybe utilize a social worker, for example, who will inquire about her needs and helps the patient and mother communicate that to the hospital staff so everybody has a better understanding and communication and coordination of care, leading to a better outcome. And from this perspective, the way to address the disability, in addition to treating the patient, is to change the environment, to work with the people who are caring for our patient population, which is what the social model is. As a healthcare provider, the focus on treatment is at the heart of the work that we do. However, we should always encourage others to view the person with an intellectual or developmental disability as a person first, and that their disability is only one facet of who they are, and consider the environments and the supports that surround them to improve the quality of care. So for our discussion this afternoon, we want to highlight the ways to consider the environment and how we think and interact with people with intellectual and developmental disabilities, and reduce the barriers that negatively impact across access to quality of care. So the first step, what we want to do is to get a better understanding of the conditions that we're going to be referring to. So an intellectual disability is a term used when there are limits to a person's ability to learn at an expected level and function in daily life. Some examples include Down syndrome, Fragile X syndrome, and fetal alcohol syndrome. Down syndrome is the most common chromosomal condition diagnosed in the United States. Down syndrome occurs in about 1 in every 700 babies. A developmental disability are a group of conditions due to an impairment in physical, learning, language, or behavior areas. Some examples include cerebral palsy, autism, spina bifida, and intellectual disability. Cerebral palsy is the most common motor disability in childhood. Based on CDC rates, 1 out of every 36 children are now diagnosed with autism. One of the important things to take away from these two definitions, intellectual and developmental disability, is one doesn't always correlate with the other. It's important to note that not everybody with a developmental disability has an intellectual disability. If you have cerebral palsy, autism, spina bifida, doesn't mean that you have an intellectual disability. It doesn't mean that you can't take care of yourself. It doesn't mean that you can't go to school or graduate or have a family or have a job. We want to make sure that we break down every stereotypical barriers, but we want to make sure we understand the definitions and the conditions. A friend and colleague and a professor out in Long Island, Dr. Stephen Shore, once said, if you met one person with autism, you've met one person with autism. And that goes for any individual with any type of disability. So the first thing we also want to identify, or next to understanding what the conditions are understanding what all the barriers are. Commissioner McDonald, Commissioner Neifeld has already went through some of them. And understanding the barriers is the first way to overcome them. So I put down a few here. There's multiple barriers. So when we talk about communication, that's obviously a understandable reason why there's going to be a barrier. Is the individual verbal? Are they nonverbal? Are they dysarthric? How do they communicate? Do they use facial gestures? Do they use an augmentative communication device? Do they use hearing aids, sign language? So I'm a family physician. I'm a primary care physician. So in a busy clinic, it can get pretty hectic and things can move, unfortunately, pretty fast. And not every physician or dentist may be able to take the time to understand how to communicate with that individual. But if you can't get past that and understand the baseline and understand how to communicate with that individual, then that's the biggest challenge that we see. As Commissioner Neifeld said, that architectural, physical barriers are a huge obstruction to healthcare, and I've seen that firsthand. Not only buildings that don't have maybe widened doorways to allow wheelchairs to go through, or staircases where there's no accessible elevator. I think one of the biggest architectural issues, physical issues I see, are in the exam room itself. How do you transfer the patient onto the exam table? I think that's the biggest challenge. As a family physician, I'll from time to time make referrals to different specialists. And unfortunately, the specialists in the community and in the hospital systems that I work at are large, and I don't always know who they are. So one story that I had was, I was with the primary care provider, this young female. She worked at cerebral palsy. She was obese, a little bit on the, had some behavioral issues, lived in a group home. But she didn't get proper women's health care. She just transferred from a pediatrician that had been taking care of her into her 20s and 30s. So now I wanted to refer her to a gynecologist to provide proper women's health care to do a full evaluation. So I was able to identify a couple of gynecologists, and I got the contact number of one gynecologist in the South Bronx area. So I called this gynecologist. I introduced myself, told her who I was, where I came from. And I told her about this lady that I wanted to refer her to make sure that she understood the patient that she would be accepting and seeing and taking care of. I gave her the history, I gave her the physical exam, gave her the background. So she agreed to see my patient. We set up the appointment. We sent over the medical notes. We sent over the medication list, any pertinent previous labs, exams, any information we could send, we sent over. We made an appointment, first visit in the morning, because this individual can't wait too long, doesn't like the bright lights, doesn't like loud noises. So we're able to accommodate all her needs, address all her needs. So the morning of the appointment, I get a call from the gynecologist. And she said, Dr. Sissoko, when such and such comes to the clinic this morning, can you make sure the group home staff bring at least 3 or 4 more additional staff? I said, well, why is that? Well, we need somebody to help transfer her out of the wheelchair onto the exam table. Well, needless to say, we had to cancel the appointment because that's not, unfortunately, the job of the group home staff. And there was only one staff for about maybe 2 or 3 other individuals that were also going to see this physician. So I think when you talk about physical and architectural barriers, those are some of the biggest barriers to care. There have been studies in the past where there was one study out of a university several years ago where they surveyed about 1,000 individuals, half with disabilities, half without disabilities. And the question was about women's health care. And they were questioning those with disabilities. What was the biggest barrier? What was it that you were not, why were you not able to get your breast cancer screens or cervical cancer screens? Why would you not be able to follow up with a gynecologist? And the finding from the study was the one main reason why they didn't follow up, why they got lost to care, wasn't because of the physician's attitude or the waiting room or the long length of stay. What they found was the individuals just couldn't get onto the exam table to complete the gynecological exam. And because of that, they were lost to follow-up. So when we talk about appointments, it's one thing to make appointments, the time, the day, but it's also important to know to prepare for the visit. So getting the appointment at the right time, the right day, but also making sure that the right equipment, height adjustable exam tables, enough staff, a Hoyer lift, if even possible, is available to the individual so that when they're there, they can be taken care of. But also the duration of the appointments too. When I see patients with, for example, maybe with Down syndrome who are ambulatory and can converse and they're walking and they can communicate, it'll be a very different visit if I am dealing with a patient who may have autism and profound intellectual disability, who's nonverbal and may have behavioral issues and lives in a group home, or somebody with cerebral palsy that is using a wheelchair and is obese and has multiple issues. So each visit will take different amount of time. So in a busy healthcare field, we know that every visit may be 10, 15, 20 minutes, but unfortunately, for our individuals with intellectual and developmental disabilities, those timeframes don't always accommodate. So we have to be sensitive and understanding that more time is going to be needed for those appointments and making sure we let the providers know about that. Transportation has always been an issue, unfortunately, especially here in New York City. I know it's a challenge for those, especially that live in the group home setting. You may have one van that's transporting 3 or 4 individuals to different appointments, maybe at one clinic or multiple clinics throughout New York City. Sometimes calling Access-a-Ride or getting a taxi or getting some type of transportation set up can take 24, 40 hours beforehand just to get it all set up. If there's an acute issue, it could be a big challenge. So transportation is unfortunately a big issue. Education and training, again, as Commissioner Neifeld said, that is probably one of the reasons why we're here, because unfortunately, as a family physician, when I was going to medical school, when I was doing my residency in family medicine, there was no training on how to take care of the population. There was no insight in terms of understanding what the social determinants of health are for this patient population. And that was a big barrier. When I came out, I was fortunate to have connected with other physicians and nurses and other specialists in the field. It's a rare breed, but I was able to connect with them and learn from them and get mentored by them. In my own personal experience, I learned just as much from the nurses in the group home, as much as the physicians, as much as the specialists. So education and training, unfortunately, is a big barrier. The Special Olympics did a study several years ago where they queried over hundreds of students as well as medical school deans across the country. And what they found was probably less than 30 or 40% of the medical school deans felt that their graduates were competent to take care of an individual with an intellectual disability upon graduation. Diagnostic overshadowing is another big barrier to care. And basically this means an individual's behaviors, what they're exhibiting, are attributed to the intellectual and or behavioral component of that individual, rather than understanding what the medical or clinical issue is. So for example, I may have a patient who has autism, profound intellectual disability, who is nonverbal, has behavioral issues, complex medical needs. Patient individual starts having a behavioral outburst, starts slapping their face and they're not able to communicate, they're not able to speak. The staff isn't understanding what's happening. They just know that this person's getting more impulsive, more aggressive, more angry, lashing out at himself, lashing out at others. And the first thing they're thinking of doing is let's send them to the psychiatrist and see what the psychiatrist has to say. Maybe they need to add another medication or increase the dose. and not even realizing that maybe it's something as simple as a toothache or an upset stomach. So that's what we always want to avoid with diagnostic oversharing, because that unfortunately contributes to the barriers that we're talking about. So I want to take at this time to hand it over to my colleague, Dr. Steve Sulkes. Thank you.
The roles that we have as healthcare providers are many and varied. When we're working with people with intellectual and developmental disabilities, we can be people who are screening and helping to identify the developmental disability, particularly when we're working with children. We can get involved at the level of diagnosis by doing the test that helps to clarify what's going on and maybe even the underlying cause. Big focus for today's discussion is how we can best provide ongoing healthcare for people with intellectual and developmental disabilities. And one thing that is an add-on, but it's almost an essential add-on, is that we get involved in advocacy. And when I say advocacy, I mean advocacy for the individual, and also sometimes advocacy for groups or communities. And it's interesting because there are a lot of advocacy issues floating around in the chat right now that I think could bubble up in our discussion later. But these are roles that we have to greater or lesser degrees with every patient we see, every individual we work with in healthcare. To begin addressing some of the barriers that Vincent mentioned, the main point that I want to make is that we need to think about individuals as individuals and adapt to their needs. And that sounds pretty straightforward, except it happens much less well in the world of IDD than it does in other situations. And we live in a world that, for reasons of economy or whatever, ends up being one size fits all, which just doesn't work. It doesn't work for anybody, really. But if you are out at the end of a bell-shaped curve, you are not going to be well served by any one size fits all kind of approach. As has been said, having accessible physical space is really important. And the point about scales was made by Commissioner Neifeld. The point about exam tables was made by Dr. Siasoko. And I can emphasize those, but I want to actually take this time to talk about sensory issues and time issues, because I think they are things that are less often considered. Having a health environment that accommodates people's individual needs involves making some adaptations. And none of us, nobody on this webinar is 100% comfortable in healthcare environments. We have our clothes taken off. We are sitting in a cold chair in an empty room waiting for something to happen. We are by nature one down and feeling out of control. And for people with developmental disabilities, that can be amplified. So doing things to make people comfortable, making everyone comfortable, can be very, very helpful. So some of the sensory issues that are mentioned here, like low lighting, quiet waiting areas, allowing people to wait not in the waiting area, but somewhere else until their appointment time begins. I will tell you that more than a handful of times, I have actually seen patients in their cars because they wouldn't come in, but I could do what I needed to do in their space. And there was no reason not to do that. Still charged for it, still got the time, still got the time in. In our clinic here in Rochester, we have the good fortune to have a sensory room. We see a lot of patients with autism spectrum disorders, and it's a nice small room with nice sounds, smells, lights, and many people will choose to go in there while they're waiting for their appointment to begin. The timing of the appointment is, as has been said, important. put it at the beginning of the day, put it at the end of the day, so you can let it run long. Or what I'm about to say is heresy, charge for your time. You can do that. Okay, if you book one patient for a double slot or a triple slot, you can bill for the time you spent because you needed to spend it to serve this person as needed. It's important also, and we'll come to this on the next slide, to let the individual pace the appointment. If it's not going well, wrap it up and bring the individual back for another visit later, or take a little bit more time. But if you see your patient starting to get agitated, do just what you need to do today and finish it up another time. It is these kinds of adaptations that help it work. I actually often say to general pediatricians, the only advantage I have as a developmental behavioral pediatrician is that I have the time to spend to get to know my patients. And it's great. We play, we goof around, we have a good time. I really do get to know the patients, and that changes my attitude. It makes me drop my assumptions about what's going on with the individual, and it lets us have a relationship, which is the goal. Communication is super important, and this has also been alluded to, but if you come away with nothing else from this session, let's talk about communication, because this is the one. Okay. The main thing that you can do to help your visits go better is find out how the individual communicates, how the patient communicates. If a person came in speaking Mandarin, you would do what you needed to do to find an interpreter so that you could communicate with your patient. If your patient comes in and is described as nonverbal, nonverbal doesn't mean non-communicating. Nonverbal just means not speaking. So find out how it works. I've had patients who were described as nonverbal who just couldn't hear and nobody had checked. And when we gave them amplification, they were able to answer questions really well. It's not just the health provider, him or herself. It's also the whole team. It's the staff. It's the people at the desk. It's the nurses and techs who are checking the patient in and checking them out. Everybody needs to find out how to communicate and what it's going to take for the person to be comfortable. Using visuals can make a big difference. We provide visual schedules for the visit that say, first you're going to get weighed, and then a picture of blood pressure cuff, and we have them laminated and we hand them out to our patients sometimes who need to know what's going to come next. The other thing we need to do is resist the urge to fall back on jargon, to fall back on abbreviations. When we as professionals are uncomfortable, we fall back on the speech that we learn in learning our craft, and that's not speech that everybody else uses. So we need to talk in normal language to people and make sure and check for understanding. Use talk back. Have people explain back to you what they understood. One other communication point before I leave this slide. This is communicating with the patient, the individual being served. We also need to communicate with our colleagues. And in an era of electronic records, health information gets shared. And I've discovered from conversations with self-advocates that nobody knows what's on their problem list. You probably don't know what's on your problem list, but it's worth asking the health provider to turn that monitor around and show you the problem list, because that is the base of the relational database that is an electronic medical record. And when the patient shows up in the emergency room, the first thing they're going to look at is the problem list. And if the individual has pica behavior, puts non-food objects in his or her mouth. That's something the emergency room needs to know so they don't put edible things or things that shouldn't be ingested near the individual. If the person is a wanderer, put that on the problem list so that everybody knows. Okay. But use the electronic medical record as a communication tool and make sure that the terms that are there are acceptable to the individual. Vincent already talked about diagnostic overshadowing, and I can't emphasize enough the problem with that. Okay, people get stuck on the person's developmental disability and ignore that this may just be a regular health problem in a person with developmental differences, and it gets in the way. It has, over multiple studies, has shown that it extends like hospital length of stay. It results in people's problems being missed. We sometimes, because of the communication challenges that people present, will not be able to make clear what their symptoms are, or the symptoms might be felt more emphatically in that individual than in somebody else, or less emphatically. And as Dr. Siosoko said, behavior is communication. When a person is having a problem with behavior, a behavior change of any kind, the first thing to do is to look for possible medical reasons for that behavior change. They're often there. And I'm talking not just about the emergence of self-injurious or aggressive behavior. I'm talking about people with Down syndrome who everyone thinks might be showing signs of dementia. It might be a medical problem. So do a good medical workup first. When we're concerned about pain and we can't figure out where it might be despite a good physical exam, sometimes we will use lab tests like a white blood cell count or a SED rate or a CRP to look for markers of inflammation. Sometimes I will have people give a trial of acetaminophen, Tylenol, or ibuprofen to see if treating pain changes the behavior in some way. But these can be helpful tricks to tease stuff out and make it possible to actually examine the person. When I have been doing primary care for people with developmental disabilities, I realized that there are some health issues that bubble up more frequently in people with IDD. And I made up a little mnemonic for myself. And those of you who may want to do a screenshot of this. I'll leave it up long enough for that. But what we did was we looked at people's problem lists and looked at what the top 7 most frequently occurring problems were over several different settings. And these were the things that came up most frequently. And what we realized was that during our well person visits, we actually just ticked these things off and made sure we were thinking about them all. Then the reasons that the people came in for acute problems were regular things that were typical for their age, with the exception perhaps of seizures, which might be more common in people with intellectual and developmental disabilities and create acute problems. But the other thing is that you, as a primary care provider, don't necessarily need to be an expert in every one of these things. You just need to ask about it, because sometimes you may be able to address the issue on your own, but maybe not. And maybe you want to get the help of a motor therapist or an orthopedist, get a dietitian to help you out with a diet that the person can handle. Get the neurologist involved in seizure management, etc. But if you don't ask, I can't tell you how many of my patients don't have dentists. I can't tell you how many times people have said, yeah, he's constipated. How did you know to ask? These are common things, and you can be a hero by asking about them. Are there the advocacy one? Are there any papers you need me to sign today? Things like that. So again, I could spend a whole session on this, but in the interest of time, I'm going to go on and sum up that we need to treat people as individuals without judgment. We need to be realistic with expectations and be honest about what we can do. But that said, none of this, nothing we've been saying today is beyond anybody on this webinar. Okay, there will always be people whose challenges are more than we can handle. We need to accept that we need consultation and help in managing things, but we can listen and attend and use our knowledge and relationship with a patient and family to serve them well. And if you do that, if you're just a listener and find out what the person's goals are and what they want from their healthcare interactions, you will be beloved by your patients. Give it a go. It's fun. And with that, I believe I'm going to turn it over back to Dr. McDonald.
Yeah, thank you, Dr. Sulkis. That was great. Really appreciate that. So I think what we're going to do is spend the next 20 minutes or so talking through some questions for you and Dr. Siasoko. And so what I'm going to do is just put up some questions, and then we'll just walk through these, and I'll just call on you for a little bit. But I thought maybe we'd start with you, Dr. Siasoko. And I'm going to ask this question of Dr. Sulkis as well. So why did you choose to specialize in the intellectual and developmental disabilities field, Dr. Siasoko?
I think if I have to go way back in my background, both my parents were in the healthcare field. My father was a primary care physician. My mother was a social worker at the Rusk Institute, working with stroke patients, traumatic brain injury patients. So that really kind of started the interest. But during my college years, I actually started working part-time while I was going to school as a DSP, a direct support professional, working at a couple of group homes out in Long Island. And I became a coach for this new organization that was new to me when I was in college called Special Olympics. And I just fell in love with working with the population and knew I wanted to stay in the field. Whether I was going to be a physician, a physical therapist, I knew I wanted to stay in the field. So that's how I became involved with it. And when I went through medical school residency, I just became keenly aware of the lack of training. So it was a bit of a struggle for me, especially when I was towards the end of my family medicine training, still waiting to get taught on how to take care of this patient population. But again, as I mentioned, I was fortunate enough to have found physicians and nurses in the field that were able to work with me, train me, and be my mentor. So when I came out of residency, I was able to take care of the population. But it's always an educational learning process. I learned not only from physicians and nurses, but also just as much from my patients and families.
Yeah, thank you, Dr. Siasoko. Dr. Sulkis, do you want to chime in on that? Just be curious about your own story in that regard.
Sure. I was a pediatric resident in the late 70s in Syracuse, which many of you will know has always been a hotbed of advocacy in the world of developmental disabilities. And I knew nothing about this. And I got to the middle of my residency and had a rotation that got me into the community, where I started seeing kids outside of healthcare environments and realizing that these were people. These kids had lives. They were having fun. They were doing everything that kids did. And I had this narrow healthcare perspective of people of people with developmental disabilities as difficult patients. And seeing what I saw in the community was kind of an epiphany for me. And I said, wow, I could do this. I like this population, and I want to help make healthcare environments better for these people than they have been. So all of my prejudices got flipped, and I became an advocate.
Yeah, Dr. Sulkis, I love the way you said that. It's interesting when you said, perception early in your career about difficult patients, because I really found the same thing you did. I didn't find anybody was difficult. It was just a matter of just meeting people's needs where they were.
Yeah.
Which really is really the heart of health equity. And I think this is why we work together to eliminate health disparities. You know, we treat people with the needs they meet. I'm going to go to the next question, and I think this is something you saw a little bit of this in the chat a little bit, as well as what is included in the training for working with people with intellectual and developmental disabilities that is not included in standard medical training. And so I'm just going to ask Dr. Siosoko if you want to just maybe throw some thoughts on that one at first here. Any thoughts, Dr. Siosoko?
Yeah, I mean, there's more than a few that's not including standard medical training, didactics. For example, standard patient models, right? So medical students will maybe use actors to go and do a physical exam on a patient. So they don't always use standardized patients who have a disability or have behavioral disorder. So when they're getting this training, that's not available. I think learning how to communicate with individuals, we always talked about that, that's a big issue. And understanding how to coordinate the care. I think the challenge with training future physicians and nurses and dentists is that those that are teaching don't necessarily have the expertise as well. So having students understand, well, how do you coordinate the care once they leave your exam room? Who's taking care of them once they get back home or at the group home? I think that's some of the training that needs to be part of the medical school curriculum.
Yeah, thank you, Dr. Siosoko. I think, Dr. Sokas, let's do this next one for you, if you don't mind. What do you think is the biggest barrier to accessing care for people with intellectual and developmental disabilities?
Oh, boy. Well, Vincent had the slide with all the barriers, and I think that ultimately it's health providers feeling like they don't know what they need to know, because it's actually not hard to adapt a physical environment. It's not hard, despite what some people in the chat are saying, to convince your office that you're going to have a double appointment and charge for the time. Transportation can be helped, but if we don't think we know what we need to know, then and that comes with the attitude issue. That ends up being the biggest barrier. And the second one that I'm just going to go back to the training on for a second is helping people learn to listen to how people with intellectual and developmental disabilities communicate, and recognizing that what looks like a challenging behavior might be the patient trying to tell you something.
Yeah, I think that's a wise way of looking at that. I think that's a really good point. Is a challenging behavior actually a symptom of something else going on? So Dr. Siosoko, why don't we go to this fourth question for you, if you don't mind? What do you think is the most rewarding element of working with people with intellectual and developmental disabilities? Do you have any thoughts on that?
I think that's one of the reasons why I went into medicine, is take care of patients, and I think when you've got a good outcome, that's the most rewarding thing. I think, just seeing the smile, the raised eyebrow, or whatever facial gestures, used to communicate with me through my patients, is just rewarding enough, and having families trust you and, go to you when needed. I think that's the most rewarding element.
Yeah, thank you so much. And then, let me just do the next question with you, Dr. Sulkus, if you don't mind. What is the greatest challenge with working with people with intellectual and developmental disabilities, and how can this be overcome?
I think I've already spoken to the time issue. It takes time. And many of our colleagues have run into problems with their employers because because you don't have the time. And unfortunately, and this is true pretty much nationwide, Medicaid reimbursement, which is often a primary reimbursement strategy, if you're serving only people with IDD, then odds are you are working in a world that is primarily supported with Medicaid funding rates, and that can be a problem unless you're a special clinic. And that is something that we are working on through some public advocacy activity to help get better reimbursements at the through HRSA rule changes.
Yeah, thank you, Dr. Sulkus. Dr. Siasoka, I wonder if you have anything to add to that as well. I feel like it's one of those things where, different healthcare providers might see that differently as well. What are your thoughts there, if you don't mind?
Yeah, I mean, I think it's understanding also the supports, who's supporting the individuals once they leave your exam room, how are they taken care of in the community? I think, there's wonderful supports, there's care coordination organizations, agencies like OPWD provide supports, but understanding that and knowing how it works, but also getting the families to understand what those resources are and how they can access it. So it's when you take care of the individual, you also, want to make sure that they have the support and families understand how they can access it.
Yeah, thank you, Dr. Siasoka. And I know we are getting some questions in the chat. We will answer some of those toward the end of our time. We're going to go through a couple more questions here, but I do want to get to Izel and Clara Poland as well. So I just want to make sure people in the chat know that we will do your questions at the end as much as we can. And let's just go to the next question if we don't mind. And Dr. Sulkus, I thought I'd start with you in this one. What tools do you use to make the experience of a person with intellectual and developmental disability better when they receive care?
So actually, we are in a fortunate time because technology can be our friend. So there is the experience during care, which is one of being, which involves using whatever communication tools we have available to us, as well as having some adapted environmental adjustments. But as Dr. Siasoka was saying, coordinating with all the other systems of service that people with intellectual and developmental disabilities intersect with, whether it's health, DD, mental health, legal, social services, helping to coordinate between all of those different service systems, it is, I think, what helps people's lives get better and gets us beyond being technicians who only address the narrow medical issue.
Yeah, thank you, Dr. Sulkus. Dr. Siasoka, anything you want to add to that?
Yeah, no, I echo what Dr. Sulky said. I think, in regards to tools and making the experience a better one, as a physician, I think pre-visit planning is so key. Care starts before the patient comes into our exam room and continues afterwards. So I think if we can make all the connections and get all the information prior to the individual's visit, it could make it a better experience. And also make sure our own staff is aware of some of the challenges that may present with an individual for whatever reason, be it behavior or physical, so that it's a smooth process when they come to our exam room and when they go through it and when they go home. And we hope the same thing with the hospital setting.
I'm going to add one more thing that I think it can be helpful. I use it in pediatrics, but I suspect it's helpful across the lifespan, which is making sure that the person knows what's coming and that we are let the person sort of feel in control of the interaction. When things are being done to you, it is disorienting and upsetting. But if you feel like, okay, I held the stethoscope in my hand, I held the otoscope in my hand, I examined the doctor's ears, okay, which happens a lot in my world. The person can feel in control and feel less anxious, and it makes for a better experience.
I think those are all good points. I think, one of the things I've done myself as a practicing pediatrician for many years is just talking to the patient. I think one of the things that's really important is to talk to the patient. Just because someone has disability doesn't mean you talk to the caregiver, you talk to the patient, because the patient's the one who knows what's going on, and the patient understands more than often people give credit to. It's really important just to show that respect, but also just, I think, to get the message across. So let's go to the next question, number 7, real quick. And maybe, Dr. Sulkus, we could start with you on this one. What are the barriers that you encounter to providing care to people with intellectual and developmental disabilities? In other words, is it physical plant, specialized knowledge, time involved? What are some of those barriers?
Well, when I'm going to speak as I respond to this to the two different worlds of healthcare. The outpatient world is one where often providers don't, they see, in fact, in both outpatient and inpatient, people see relatively few individuals with developmental disabilities, and therefore they don't feel that it's necessary to make adaptations, even though, as I said earlier, the adaptations you make to accommodate people with IDD are actually going to accommodate everybody better, and you're just going to be a more accommodating, provider. The in the inpatient world in particular, I think things get problematic again because people are working on protocols, and if no one knows how to communicate with the individual, it can be it can result in behavior challenges. And we have colleagues on this webinar who are expert at picking apart and identifying what's going on in a behavior situation that I think can be of phenomenal assistance both in the outpatient and inpatient setting.
Yeah, thank you, Dr. Sulkus. Dr. Siasoko, anything you want to add to that?
Yeah, no, I agree. When we talk about inpatient, outpatient, that's an issue. But I'm also thinking about the barriers and the challenges when somebody goes to the emergency room. I think it can be obviously overwhelming for anybody, but especially somebody with an intellectual or developmental disability. I think again, going back to communication, not just with the patient, but also with our colleagues, communicating with amongst each other. I think one of the things that the Rio, kind of getting off topic here, was supposed to connect all the hospitals and electronically get all the information. I think some of the barriers is finding out that my patient was seen in the emergency room 2 nights ago, but I wasn't aware of it until they came for a follow-up visit. So I think communication and coordination in general is just a big barrier.
Yeah, thank you. Let's do our next question here. This is question 8. And I think, after this question, we'll bring in our other speakers, Izell and Claire. But let's do question 8 next. And Dr. Siasoko, let me start with you on this one, if you don't mind. What have you seen as the repercussions of people with intellectual and developmental disabilities not being able to access adequate or competent care?
Yeah, unfortunately, I've seen way too many repercussions. I mean, not being able to access adequate or competent care can, from the inpatient setting, for example, lead to long length of stays, can lead to readmissions, poor discharges. You have hospital teams that are well-meaning but don't understand what a group home is, which is not a nursing home or assisted living facility. Follow-up visits that get lost to follow-up, as I mentioned, gynecology exams, routine preventive healthcare screenings, preventative cancer screenings, those can be missed. So when an individual doesn't have access, things can slip through the cracks. And unfortunately, that's what I've seen over the past several years.
Yeah, thank you so much. And Dr. Sulkus, I'm just curious what you would add to that.
Yeah, I was going to say that that one of the things that I see are people not getting physical exams because the providers see them as hard to examine and missing important physical findings that would result in health problems being identified. If the patient doesn't get out of the wheelchair, the pressure sore might not get identified until it's much harder to treat. If the person can't have her lungs listened to, it's going to be a hard thing. If it's hard to examine the patient's abdomen because of the position, over and over, I see colleagues not thinking about that, not doing a good physical exam, also not anticipating some of the anticipatable kinds of health challenges that might rise up as acute problems if you don't stay attentive to them early on, like in my little mnemonic earlier.
Yeah, thank you so much. I think that's great. Well, this has been a wonderful little time of facilitated dialogue, and I appreciate that. We'll come back and do some more of this, but I do want to get to our next speaker. So if I could turn this over right now to Isel Obermeyer and Claire Powell, and I think it'd be wonderful to hear from both of you at this point. So Isel, I think you're going to take it next and then go to Claire. Is that, if you don't mind?
Yes, that is how it's going to work. Can you guys all hear me?
Yep, you sound good, Isel. Thank you so much.
Good. I picked today of all days to have laryngitis, so I apologize for that. So I just wanted to introduce myself a little bit, and the facility where Claire and I work, the Westchester Institute for Human Development, is a specialty clinic focusing primarily on services for individuals with IDD. We have healthcare clinics including medical, dental, behavioral health, and allied health services. But because we're also a UCED, a University Center of Excellence in Developmental Disabilities, we do a lot more community outreach, training, and research that helps with all of the services that we provide and getting it out into the community. It's been interesting to listen to you guys talk, Dr. Silkus and Dr. Siasoko, because a lot of what you've shared is things that I work with my providers to make sure that they actually do some training in these areas. We have a cadre of providers who've been working in the field of people with IDD for many, many years. But as we bring in new providers, we make a conscious effort to work on training our staff up so that they follow the guidelines and so that they understand that what we expect here is excellent patient care. When you look at the patient, we want to make sure that you look at an individual and that you want to meet their healthcare needs, regardless of what difficulties they may come across your doorstep with. So I have the honor today to introduce you guys to Claire Poland, who is one of our self-advocates in our group called Hear Our Voices. She's a fantastic advocate for people with disabilities. And she's going to talk to you a little bit more about herself, and then she and I are going to share a little bit of a facilitated communication at the end of that. I will be forwarding her slides, but Claire, I'm going to give the mic over to you.
Sure. Hello, everyone. I'm Claire Poland. I'm honored to be here today. I'm a self-advocate, and I also work for Westchester Institute for Human Development. Public speaking, however, does not come easy to me, but I do it because I know that it'll make a difference to patients with disabilities and you as physicians. So let's get started. Doctors have always been a part of my life. My mom and dad would take me to doctors as a young girl, and sometimes I am surprised at just how young I was when I started knowing the difference between good medical care, not so good. Patients know the difference, even the very young ones. What helps? Well, let's start with a positive experience I had. When I was 10 years old, I had a life-changing operation in my eyes to correct my sight. This was a scary and vulnerable time because the surgery was all the way in St. Louis. I was excited and nervous all at the same time the day of the surgery. I asked the nurse who would be watching me in the OR while I was asleep. This was somehow important to me. She looked at me with like a puzzled look, like she didn't know. So I spoke up. I said to the surgeon prior to the surgery that I wanted to know who would be watching me in the OR. He took a second and proceeded to say, "Well, give me a minute," and proceeded to leave the room and come back with the entire surgical team and introduce them to me by name. This meant so much to me. I felt seen, I felt heard, but more importantly, I felt respected. And this small gesture made me feel even more optimistic about the outcomes of the surgery. I still volunteer my time for this hospital, and more importantly, tell others how great it was to be a patient there. What hurts? Well, let's go with a more difficult story that I experienced. I was waiting in an emergency room with my mom, waiting to get care for stitches. We came closer to the check-in desk where the triage nurse was sitting. She looked at me and then looked at my mom. She says to my mom, "Is she competent?" Now, I agree that one of us may not be competent, but maybe it is not me. I understand that it is important for any medical professional to assess anyone's level of functioning, but your first assessment should always be with the patient, and you should always try to get them involved the maximum extent to their care possible. Closing thoughts. Try your best to communicate with me. Assume I understand more than you think I do. Consider my privacy needs. Lastly, I am anxious because of past experience, not my disability. I would like to elaborate on 2 of these points. Number 1 being, assume I understand more than you think I do. I work with individuals, mentoring them, and a lot of them are nonverbal. As many of our presenters have said, that doesn't mean non-communicating. They understand way more than you realize. They know what's going on. So be sure that you know that they're human too. And even if it takes them a second to communicate with their iPad or with nonverbal signals, know that they are trying to communicate something. And lastly, the last thing I want to elaborate on is consider my privacy needs. For this one and for the other one, I am not just talking about me. I'm talking about individuals in general. When an individual with a disability comes into your office, think about the fact that they might be a mature adult and they might need you to consider that they might not want their caregiver or their mother in the room. Privacy is just as important to us as it is to a neurotypical individual. So always ask us and our parents, or even just us, what we are more comfortable with. Thank you for your time. I'm happy to answer questions at the end.
Okay. Thank you, Claire. Can you hear me?
Yes.
Okay. So Claire and I prepared a little facilitated communication just to showcase the conversation between a provider and a patient who wants to visit the facility. Claire has prepared some questions for me. She's coming to our facility to find out about the services we provide and to give us a better sense of what her needs may be. So Claire and I are going to share this with you.
Hi, hi, Dr. Izell. I'm looking for medical and dental services for people with disabilities. In particular, for for people with disabilities, but I need someone who's really good with someone with a startle reflex because I have a really difficult startle reflex.
Okay, so welcome, Claire, to the Westchester Institute for Human Development. I'd be happy to tell you about our services. We have both a medical and a dental clinic. We also have a behavioral health clinic, and we have allied health services available as well. Our providers are trained so that they know how to work with individuals with different needs. They go through a lot of support from our facility. They do outside training as part of their continuing education, and they have experience in working with people with different abilities. So when you come to our clinic and you explain to a provider that you have this pronounced startle reflex, they will know how to deal with that, and they'll try to make sure that it best meets your healthcare needs.
Okay, great. I have a few questions for you. Is that okay?
That's wonderful. The more we know about you, the better we can serve you.
Okay, first question. Do you have accessible parking for people with wheelchairs and walkers to get in the building? Because oftentimes it's hard for me to walk really fast to my appointment, or even with my wheelchair, sometimes we need like space to park, our cars so that we can get the wheelchair out.
So yes, we do have accessible parking. What we typically recommend is that people use the one-way road directly in front of our building to drop off people who have difficulty with mobility, and then go around to park in the parking lot where we have handicapped accessible parking and a ramp from the parking lot down to our facility. And once you come in, the whole building is also accessible. So it is easy to get to the different clinics, even though we have our medical clinic on the second floor and our dental clinic on the fourth floor. The elevators are large enough that they can handle not only a wheelchair, but also patients who come to us on stretchers or other mobility supportive devices.
Okay, great. And then the second question I have is, are your offices big enough for me, my wheelchair, and my staff member if I needed them or wanted them in the room?
Yes, our offices are. Our dental operatories are smaller than our medical exam rooms. In a medical exam room, there is ample space for everybody. So you can bring your basketball team with you if you wanted to, but there's enough room for you to bring your wheelchair in. There are Hoyer lifts to help transfer you from the wheelchair to the chair if that's what you may need. In our dental operatories, the space is a little more compact, but we still have enough space around the dental chair so that a patient can transfer from a wheelchair into the chair. We also have dentists who are trained, if a patient is more comfortable staying in their wheelchair, that they will see the patient in the chair. I listened to some of the people earlier who explained that they went out to the car. So I see our providers out in the parking lot often to talk to patients when they're in their van. So we definitely have the capability to transfer you, but we can make it work with any need you may have.
Okay, and then do you have a quiet place where I can relax before an appointment, or in case I get anxious waiting? Because oftentimes I get anxious in medical buildings. It's overwhelming.
I absolutely hear you. Our waiting areas are pretty busy. I will not lie to you about that. But on each for each clinic, we also have private waiting space so that if you need to be in a quieter area, there's a smaller waiting room off of the big wait spaces that are specifically for people who get anxious. And then in addition to that, if you need more than that, we'll be happy to find an exam room, an empty exam room for you if you really need to be away from anyone else. That is something that when you come here, our receptionists really are trained to be able to accommodate this. So just go up to the reception desk, talk to one of them. If they don't know how to help you, their direct supervisor will. And if he doesn't, he bumps it up to my office and I'll come out and help you.
Okay. And also, oftentimes I like to go to my appointments on my own, but I sometimes cannot remember important details. Is it okay if I record the session with the doctor?
I say that it's usually a good idea to just ask the provider if they are okay with that, but we train our providers to actually recommend it so that I just know if I go to the doctor, especially if I have a significant healthcare issue, I'm anxious enough that I don't remember half of what they told me after the fact. So I think it's a really smart idea that you want to record it so that you can share with your significant others the details you want after your visit.
Well, thank you. If I have questions for my doctor after my appointment, how easy is it to call? Because I often get put through to a phone tree when I call places.
Yes, I'm not going to lie to you. We also have a phone tree. And if the front desk is exceptionally busy, they may not be able to pick the call up when it comes in. But I urge you to please leave a message when you call, because I check our phone tree on a regular basis to make sure that people do call back. So it's our philosophy that we will not leave messages by the time we leave at the end of the day. So you should get a call back. And we often make sure that we give the message to the provider also before they leave for the day so that they can call you back if that is the request you may have.
Okay. And then, do you have a patient portal?
We do have a patient portal as part of our electronic medical record. You sign up for it, and then it gives you access to all of your medical records right there in your private portal.
Okay. Is there any way to have staff that can help me learn how to use the patient portal? Because I often need assistance because I'm visually impaired.
So yes, we do have the manager of our electronic medical record can help you with the portal. Excuse me. And she will, when you sign up for the use of the portal, she will be the one to train you on how to use it. But when you come back, you can always talk to the medical assistants or the providers. They are all able to help you.
Okay. Do you have any questions for me about what I may need?
And my biggest request is that you keep on talking to us throughout your relationship so that we can meet your needs to the best of our ability.
Great. Well, thank you. Thank you for talking to me today, and I will see you soon.
Thank you, Claire. It was nice to get to know you. Welcome to WIHD.
Thank you.
Yeah, well, thank you so much here. So I think that was great to hear from Claire. Claire, I found that very informative. Really, really appreciate your presentation. I love the perspective you did on so much of that. It was just really well done. And Isla, I really love the question and answer time, that little discussion that you just held. I thought it was really very informative. So very, very grateful for that. I'm going to move now to some questions that received throughout our time together. We won't be able to do all the questions, but I do want to do a few of them just as we can go through our time together and see if we can't answer some of these as best we can. So, I know there was a question in the beginning from Maureen Ryan, and Maureen, thank you for your question. And so Dr. Siasoko and Dr. Solkis, let's look into this one. Maureen says, I frequently work with patients with autistic spectrum disorder who run into barriers related to accessing Office of People with Developmental Disabilities. Even with extensive psychiatric evaluation completed by child and adolescent psychiatrists, unable to qualify as no autism diagnostic observation schedule. Agencies in our area that complete the autism diagnostic observation schedule have plus 1 year wait list. Additionally, the autism diagnostic observation schedule has a higher false negative than other measures, according to my understanding. What suggestions do you have so that there isn't such a long delay to even start the Office of People with Developmental Disabilities application from time of diagnosis by a specialist? So I just start with Dr. Sulkis and Dr. Siasoko, and I don't know if Commissioner Neifeld wants to address this as well, but let's see if I can just get some input.
This is an area that I swim in a lot, and so I'll take it. There are two parts to this. Part one is the rules for OPWDD service access, and the second is the long delay for autism diagnostic services. We in our clinic in Rochester do administer the ADOS, as mentioned, but you got to be trained in it. You got to have the kit, and the other measure that was mentioned, the Childhood Autism Rating Scale, is, I believe, another acceptable measure that can be used in confirming an autism spectrum disorder diagnosis from the perspective of OPWDD. The gold standard ultimately for autism spectrum disorder diagnosis is the DSM-5 criteria, and that is going to be that, and the other things that we've mentioned are measures that support DSM-5 criteria. So we use a combination of those tools, but it takes time. These visits are time consuming, and we find that our waiting list is frustratingly long as well.
Yeah, thank you, Dr. Sulkis. Let's go on to the next question here. Sonia Maxwell asked, are there tools available to assist healthcare providers in asking nonverbal or intellectual or developmentally disabled patients about their sexual orientation and gender identity? Dr. Siasoko, I don't know if you have an answer to that off the top of your head. I just can ask you or Dr. Sulkis. What are your thoughts?
So in regards to specific tools, I'm not aware of any specific tools, and Dr. Sulkis, chime in if you are. I think, asking certain questions can be a bit challenging. I think it's just a matter of getting the information from the individual as best you can. The concern comes up if they're not able to communicate, then who do you go to in their world, be it a caregiver or a family member?
Can I respond to that as well, Dr. McDonald?
Oh, thank you, Isel.
The speech language pathologist who work in our assistive technology clinic has actually recently endeavored to try and change the world of allowing people with communication devices access to the symbols for private parts and for sexual orientation questions, because most of these tools hide those images in the back. So I just wanted to share that it is possible for people to actually be able to answer those questions on their devices if the person who helps them program their device knows where to find them. So if that's a kind of question you're going to ask, I would recommend that you speak to the people who support their communication devices and just make sure that they reprogram the device so that these questions are more easily be able to be asked.
Yeah, thank you, Isel. Let me go to another question, if folks don't mind. So Maylen Anderson asked the question, so can the speakers address emergency department challenges and solutions which can result in not only poor quality and experience of care, but at times harm and trauma? Dr. Sulkis, can I put you on the spot for that one?
Oh, I'm sorry. I was focused on answering a question in the chat. Could you just repeat it real quickly?
Sure. Oh yeah, no. So May Lynn asks, can the speakers address emergency department challenges and solutions which can result in not only poor quality and experience of care, but at times harm and trauma?
Yeah. Again, and Dr. Siasoko, I'm sure is going to want to weigh in on this too. The emergency department is a place that is often crazy, and it is, and there is, it's noisy, it is stressful. When you come to the emergency department, any of us, it's going to be a stressful time. And I have to say that having people just aware of the communication needs of accessing electronic medical records about the individual so they know what's going on with the person can probably be the two most helpful things. I had an experience in Rochester where there was a bus crash from one of our local developmental disabilities agencies, and all the people on the bus were brought to the emergency room at once, and we had a hospital-wide disaster kind of drill. Not a drill, but I got called to the emergency room and was amazed at how well the emergency room team was handling this. And we were trying to figure out who these people were and look up their records, and it worked out. It was amazing, but it took a lot of thought and a lot of coordination. Vincent, you should respond to that too.
Yeah, I mean, if I can chime in, I'm echoing Dr. Sulky's, words. ER can be overwhelming. I think, obviously, again, going back to lack of education training for ER physicians, residents, and training. I always look at patients coming from two different worlds, coming from the community that they may live on their own with home attendants or family members, or those that live in a group home setting. And when individuals come from one of those settings into the emergency room, the ER physicians, the nurses, the ancillary staff have to have a better understanding of where they're coming from, because I think that's where the communication is going to really be key. So, for example, if somebody lives in a group home, they're sent to the emergency room, that physician or nurse triage, should understand, who to contact at the group home, and that's where nursing is just so valuable. They're so key to that communication and coordination. If somebody comes from the community, again, always talking to the patient first, but also understanding what the supports are. So it's important to get that information. I think also for the ER physicians, they should also get in touch with the primary care physician. I think that's been one of my challenges and frustrations, as I just mentioned, that I usually find out my patients go to the ER after the fact because they come to me for a follow-up visit. So I think encouraging physicians to get in touch with a primary care provider who, for the most part, would have access to the records after office hours or the beat on-call service. What we've done at a couple of hospitals is we actually put together a passport. And basically this passport doesn't only talk about the individual's medical conditions, medications, but it also talks about some of the triggers, what are their likes, what are their dislikes. So I think something as a passport can be very beneficial, not only to physicians and nurses in the emergency room, but also the technicians who may be getting the CAT scan or drawing the labs. So I think getting a better understanding, however that may be, to paint a larger picture of the individual will help the process of going through the emergency room a little bit smoother.
Yeah, thank you so much, Dr. Siasoko and Dr. Sulkas. That was great. There's a question here from Susan. She asked, could you please talk about the importance of listening to families of people with intellectual and or developmental disabilities? Dr. Sulkas, do you want to respond to that a little bit?
Sure. I mean, absolutely. Families, as was said, our first informant is the patient, him or herself. But if, as Claire said, the family is welcomed into the conversation, then families are key to this. I will also say that particularly when we're trying to tease apart behavior challenges, everyone in the person's environment, all the different environments the person is in, can be providing useful information. So yes, listening to families is key.
Yeah, thank you, Dr. Sulkas. Let's do this next question here, and I'll say this one to you, Dr. Siasoko. This is from Renita. Renita asks, thoughts on the best way to identify patients in the hospital with intellectual and developmental disabilities. Diagnosis codes most often represent the acute physical diagnosis and not the disability. Dr. Siasoko, any thoughts on that?
So the question is in terms of putting the diagnosis code down, is that?
I think so. I mean, I think what someone's drawing into is that often the disability is often at least a comorbidity. If someone's in the hospital for pneumonia, it's probably important to point out what is the disability as well, just so it's documented in the medical record. I would think that'd be important for billing purposes as well. That's my experience, is that you generally want to put all the pertinent diagnostic codes as part of especially when you're dealing with a hospital admission.
Right, absolutely. I mean, you want to put whether it's cerebral palsy, intellectual disability, autism, Down syndrome. That's very important. I also see the flip side of that. Well, first and foremost, yes, documentation, coding, always putting all the conditions the individual has. But you also want to be careful of not to attribute, for example, a hospitalization because they've got cerebral palsy, right? Or, you want to make sure that the diagnosis code is appropriate for the reason for the hospitalization. But I think you should always document the conditions that the individual has whenever they're hospitalized.
Can I
Oh,
add to
please
that?
go ahead. Yeah, please, Dr. Salkis, go ahead.
That another spin on that question that may have been intended beyond the diagnostic code issue is having somebody in a hospital who perhaps in a social work or nursing department who has some knowledge and expertise about developmental disabilities, who can help inform other hospital team members about good ways to work with this individual, good questions to ask, and who might be more knowledgeable about other resources than everybody else in the hospital team. So I've seen that work very well when there was when there were one or two people who were the go-to information sources for inpatient providers.
Thank you, Dr. Salkis. Let's do the question next from Dr. Kevin Munjal, who said, I'm hoping there'll be more discussion of management of unscheduled acute needs for intellectual and developmental disabled populations, opportunities for telehealth, rapid in-home, in-facility response and assessment, etc. Thanks. Any thoughts on that? I'll go with you, Dr. Sayasoka, first. I don't know if you have any thoughts. I think telehealth has been great, by the way. Like, I think if there's anything good that came out of the pandemic, it was interesting how much telehealth became something we could all benefit from, especially with the advent of video telehealth and people having cell phones. Actually, you can get some of these things done, not everything. But I mean, I've seen my own experience, like take care of a patient sometimes, on the weekend, you just can, sometimes families have a pulse oximeter at home, they have some tools. You can actually get an assessment done like, hey, I don't need to send you to the emergency department. Things looking pretty good. We can wait the morning. But I know, I'd be curious from your own clinical experience, Dr. Sayasoka. What are your thoughts there?
Oh, absolutely. I think telehealth is a blessing. It's been a lifesaver on more than one occasions. I think it's definitely adds value, especially to individuals that can't get out of their home or lives in a group home. I think it's very valuable, especially when we talk about mental health and behavioral health issues. Obviously, it can't take the place of a physical exam, so it does have its limitations, right? So we don't necessarily want to just, I don't want to say take the easy route. Telehealth is very valuable in certain situations, but we also can't neglect that patients do have to be seen face to face. Physical exams have to be performed. We don't want to use telehealth to, we don't want to use that and, risk the chance of missing something else. So.
Yeah, thank you so much. And I'm going to do a question here from Anna Maria. She asked a question for you, Dr. Salkis. Do you know where in upstate New York one can find a specialist who can administer autism testing to a previously undiagnosed adult?
So that was the question I was trying to answer in the chat when I wasn't paying attention before. I apologize for that. This is tricky. This was a very, very hard thing because most autism spectrum disorder diagnosis goes on in pediatric settings. And our clinic does as brisk a business as we could possibly ever hope for, with a huge waiting list, unfortunately, for that kind of work. And we don't do it for adults. I suggest that people look on the Psychology Today website for providers who may list autism diagnosis as a skill and contact them. That's probably the best thing to do, because then you can you can fine tune your search to a specific geographic area. If you happen to be in the Rochester or Finger Lakes area, you can contact our clinic, our developmental behavioral pediatric clinic at Goss Center Children's Hospital, and our folks know some community providers who in our community who see adults, but they're not many. It's a big problem.
Let's do, we don't have a ton of time left, but let's do a couple more questions. Karen asks, do medical providers have a set of best practices for patients who don't self-report or unreliable self-reporters? For these patients, are there more protective guidelines in place for the kinds of conditions that shouldn't be diagnosed via telehealth? or proactive, minimally invasive testing that could be added to routine ones, or a more robust review of medical records and histories for accuracy and completeness. Does the Office of People with Developmental Disabilities have guidelines that assign primary responsibility for actively overseeing quality of care as distinct from minimal compliance that a resident in server housing receives? I don't know if Commissioner Neifeld is on, if she could have addressed that as well. I've just offered that out there. But does anyone else have any thoughts on that?
I'm not aware of any specific guidelines that, again, about for when to do, when or when not to do telehealth or that sort of thing. I think it's pretty much play it by ear at the moment. But Dr. Siasoko may know stuff that I don't know.
Yeah, I mean, I think telehealth is still relatively new. So in terms of guidelines,
Yeah.
I think it's a clinical judgment call as a physician. There may be certain circumstances that I'm okay with providing telehealth or guiding staff to utilize telehealth as opposed to doing an inpatient visit. But I'm not aware of any right now.
Let's do another question here from Ani. Ani said, how do you identify dementia in an individual who has Down syndrome? I don't know, one of the doctors has a thought on that one.
Go ahead. Go ahead. You see more adults than I do.
Yeah. Well, I think that it's a challenge. I think from working with colleagues who are neurologists and take care of this patient population, I think there's no one set answer. It's really getting to know the individual and having that relationship. And as they age, understanding what are some of the changes in their behaviors of what's been going on. It's not going to be an overnight diagnosis. It's just evaluating the patient, getting to know them, and seeing what's changed over the course of, be it last few weeks, last few months, last few years. I think the important thing is when someone is brought to the clinic and they're thinking, okay, well, maybe this person has dementia because they're getting agitated, they're getting irritated. Again, going back to diagnostic overshadowing, you want to rule out everything before you make certain diagnoses. And one of them is dementia. So,
right. One of our colleagues here in Rochester who was doubly certified in geriatrics and developmental disabilities looked at this, and I think it was something like 40 people who arrived in his clinic with questions of dementia in individuals with Down syndrome. Half of them had other medical things going on that were treatable, including depression, including untreated celiac disease, including hypothyroidism, including seizures. So think about, to cast a broad medical net and look at the patient and listen to what the patient tells you before just assuming if it's a person with Down syndrome that it's dementia that you're looking at. Hearing problems, another example.
And I think I would just do this one last question, then we'll spend a few minutes closing. So Pat asked this question, are there plans to systematically assess individuals with intellectual developmental disabilities for their capacity to choose a healthcare agent and complete a legally correct healthcare proxy? This would serve to improve communication with the person, the individual trust to make decisions on their behalf based on what matters most to the person when the individual loses capacity to make decisions when acutely ill or near the end of life. Certainly an important issue for everyone. I don't know if Dr. Siasoko or Dr. Sulkis, if you have any thoughts on that. Really gets to those issues of understanding, people do know more than we think they do, and making sure their end of life wishes are accommodated and making sure they're documented before. I'm just not aware of any systematic assessment that's unique to individuals with intellectual or developmental disability. I do think it's important, though, that they have a healthcare agent and have the appropriate documentation. Have you run into this situation in your practice all that much?
Well, yeah, I recommend for every patient with developmental disability that I have who is transitioning into adult care, that, as well as everybody else, that we all have healthcare proxies. It is easy to do. It involves a notary, and you don't have to have a guardian. You don't have to go to court, but we should all have identified healthcare proxies. Capacity evaluation is a trickier process that that involves multiple steps and some time and definitely communication. But we need to start from the presumption of capacity for everyone, and only say that a person doesn't have capacity when we're convinced that that's really true.
Yeah, it's like, I want to thank you so much. And as I want to close out our time together today, I do want to thank Claire again for sharing your thoughts. I thought you really, did a great job, and really, I learned a lot from you, and I appreciate that. And Isela, it was great to have you on as well, and Dr. Sulkis and Dr. Siosoko as well. And then, thank you, Dawn, for putting in the chat earlier the 2 different courses from the University of New Hampshire that we've been working with. And perhaps you'd have time to put that in the chat again as well, so people could avail themselves to additional training should they deem that to be something they'd like to pursue. And I think if Dawn gets a chance to, again, remind people that there are previous commissioners' grand rounds that you can still avail yourself to if you're someone who needs more continuing medical education over the year. Again, highlighting, we've had some great topics we've discussed. I think, one of the things I'm taking away from today's conversation is just interesting how so customized care should be for everybody. But quite frankly, I think it's been really important to identify some of the barriers that people with intellectual and developmental disabilities face, and quite frankly, shouldn't have to. And I think it's clear that the Office of People with Developmental Disabilities is doing a lot to address those, and the Department of Health is trying our best as well. And I want to thank Commissioner Carrie Neifeld for coming with us as well. And I do want to just thank Sarah Snyder and Haley Gilmore for putting this whole program together. This is one of the important topics, and I don't think it's been covered as much as it has in the past. I'm glad we were able to put our attention and focus on this today. I think it's such an important issue as we move forward in New York. We're trying to eliminate health disparities for everyone. And one of the things that I think we need to highlight is just the importance of eliminating health disparities for people based on their ability, because it's really important that people receive optimal health care throughout their life and optimize their social determinants of health, regardless of their ability and the services that they need. And, certainly we've heard a lot of barriers identified, just access to care. We've also talked about being welcomed into the exam room, welcomed into a hospital, welcomed into an emergency department, and I think those things will stick with us. And Claire, I have to tell you, I think I'm going to remember forever the story you told about the surgeon had the wisdom to bring the whole team over to meet you and introduce themselves to you. That's the type of thing that should happen with everybody, quite frankly, because I think the idea of being under anesthesia and who's looking at me is a great question to ask. I'd want to know the same thing for me as well. And it's interesting, my wife recently had some surgery, and the surgeon did the same thing for my wife. And it was just a nice little way to make sure everyone, my wife and I, felt comfortable for who's going to be in the operating room, because a lot's going on there. Important for us to know. This has been a wonderful session. I've learned quite a bit. I enjoy having these commissioner grand rounds. I'm glad we're doing these. And I'm really very, very grateful to Christian and his team at the University of Albany, including Dawn and others who help us to make these possible. It's wonderful to get together live in person, and it's wonderful for those who can listen to our conversation at a time of their choosing when it's more convenient for them. Well, thank you for that. And with that, I am Dr. Jim McDonald, the Commissioner of the New York State Department of Health. Thank you for joining me today on our Commissioners Grand Rounds as we journeyed into this important topic area today. Please do look forward to filling out the information so you can get continuing education credits and doing your best on the post test. And again, thank you so much. Have a great rest of your day. Bye-bye.
This webcast will actually be put up on the website, Commissioner Grand Round's website, in a couple of weeks, and that will include transcripts. We've gotten some requests to have some questions from chat put up there as well, so we will try to figure out the best way to do that. But until next time, folks, thank you so much for attending, and we will see you soon.